everyone, I'm Dr. Manoj Shah. We all have seen how contagious this COVID-19 can be, and the biggest challenge becomes preventing death. Overall, if you see the world's death rate, it's somewhere around 3 to 5%. But in European countries, especially Italy, Spain and Germany, the death rate was as high as 12%. Now what was the reason behind that? One, the cases peaked up very early in all those European countries. As it peaked up early, it outnumbered the medical care available in those countries. Whereas in India and to some extent in US, they were able to maintain a flatter curve, and that happened because of lockdown. Now when the cases are flat, means you are not getting enough cases in the country. You have got enough medical care which can take care of all those patients. The second reason why all European countries had a higher mortality rate was the disease was very new for them. Hence, the triaging of patients was difficult. If they were able to find out some risk factors of patients for mortality, the triage would be easy. So I'm going to present one interesting case which again got published in Lancet. It was a retrospective cohort study, and this was from China. It looked into the clinical course and risk of mortality from two different hospitals. One was Tan Hospital and one pulmonary hospital. They saw into the patients who were either dead or discharged by 31st of January 2020. They had used univariable or multivariable regression method to explore the risk factor for mortality. So what was the criteria for discharge? So they had four criteria. One, absence of fever for 3 days, substantial improvement in the CT scan chest, and that should be for both the lungs, clinical remission of respiratory symptoms, and 2 throat swab which should be negative for SARS-CoV in 24 hours apart. There are 5 variables: age, lymphocyte count, D-dimer, SOFA and CAD. Let me go into SOFA. SOFA is the sequential organ failure assessment. It's just to see whether your organ is functioning good or it is going for multiple organ failure in ICU. Now if you go deep into SOFA score, it has got 6 variables. One looking at your respiratory function, they look at PaO2 and FiO2 ratio, then coagulation function, looking at platelet levels, liver functions, looking at your total bilirubin. You have got CNS, they take this GCS score. Cardiovascular, they look by looking into the mean arterial pressure or use of vasopressor agent. Renal, they see the creatinine and urine output. Now, there were around 813 patients who got admitted before 31st of January 2020, of which 613 patients are still in the hospital and 9 patients are without any key information. So overall, if you see, they have studied around 191 patients. 135 patients were from Tan Hospital and 56 patients were from UN Pulmonary Hospital. The discharged patients were around 137. They were called as survivors, and non-survivors, the died patients, were around 54. That comes to around 28% in that 191 patients. Looking at your median age, it was 56, but when you compare between survivors and non-survivors, the age group of survivors were on the higher side, around 69 years, whereas survivors it was 42 years. If you see by the male-female ratio, it was around 62%. Among non-survivors, the male ratio was around 70%. If you see exposure towards seafood market, it was around 38%. And when you compare between survivors and non-survivors, it was 26 versus 43. 26 for your non-survivors. This also shows that by end of January, it was already proven that we had human-to-human transmission. Because if you see, the exposure of the patients was only 38%, whereas the initial study which I had spoken in my previous video, the exposure rate was 66%. Now if you look into the associated comorbid condition, 48% of the patient had some amount of comorbid illness with them, among which hypertension, diabetes and coronary artery disease topped the few. Hypertension was around 30%, diabetes 19% and coronary artery disease by 15%. Minor comorbid conditions include COPD, CKD and carcinoma. Now if you look into the symptoms of the patients, 94% of the patients had fever, cough was seen in 79%, fatigue around 23% and sputum production was seen in 23%. If you go into the labs, 40% of the patients had lymphocytopenia and 81% of the patients who were non-survivor had a D-dimer of more than 1 microgram per ml. The median time from the onset of illness to death was 18.5 days and the median time of from onset of illness to discharge was around 22 days. 32 patients required mechanical ventilation, out of which 31 patients died. So the death mortality among ventilated patients was 97%. And the median time of onset of illness to ventilation was 14.5 days. 3 patients required ECMO and all 3 died. If you look into the complication, the rate of complication was higher in non-survivors when compared to the survivors, and sepsis was around 51%, ARDS was 31%, heart failure was seen in 23%, and septic shock was seen in 20%. Now if you look into subcategory of septic shock, 70% of the patient had normal total count, the procalcitonin level were normal and there were no bacterial pathogens seen. Hence the author felt that the sepsis can be related to coronavirus directly. Now half of the survivors experienced secondary infection and the ventilator associated pneumonia occurred in 10 patients out of the 32 patients who were ventilated. Now if you look into the duration of viral shedding, for non-survivor the viral shedding was up to 18.5 days, that is the time till death, that is mean time till death, and in survivors the viral shedding was seen up to 20 days. The maximum viral shedding was seen up to 38 days. So the author concluded that when compared to survivors, the non-survivors were of elderly age group, had elevated D-dimer score and had high SOFA score. Also, age, comorbid conditions, lymphocytopenia, elevated ALT, D-dimer, creatine kinase, high sensitive creatine, cardiac troponin I, prothrombin time and a disease severity was reported in ICU care admissions. Although this study highlighted some of the risk factors for mortality, there are few limitations in the study. Number one was sometimes the patients were referred late into the hospital. Hence, they had inadequate supportive care, antiviral therapy and high use of corticosteroids would have led to poor outcome. The second was the sample size was very small. And the third, there are still 613 patients who are admitted and their results can vary the outcome. So this study gave us a way to triage our patients in a better way. Thank you for listening and be safe. Thank you.